immunotherapy in GI cancers is terrific, particularly for a guy who's been spending the last 20 years of his life trying to make immune therapy work. And I think we have to be really careful about what we mean by immune therapy. So the breakthrough has been this thing called checkpoint inhibition. And in that situation, the immune system's already ready, it's all charged and ready to go, but the tumor is preventing it from being attacked. And so all these drugs do is take that force field, if you will, out so that the immune system can go on in and do its thing. So if that immune system's not out there, if you will, the tumor hasn't pissed off the immune system enough, then those drugs will not work. And in fact, there's some observations recently that if you give it to the wrong patient, that there are these super progressors, that their tumor gets fastly growing and is bad. So it's not one of those things that you just want to throw at patients. But we have other markers. So we have MSI, we have PD-L1, there's this thing called tumor mutational load, and I will challenge that most oncologists, including this one, doesn't really understand all the molecular testing that's going on to pick which one needs the treatment and which one doesn't. And there was a great, Wells Messersmith gave a great talk at this meeting on defining that for us so that we know what to test, in whom, how to interpret that test, and move it forward. So all of our patients with metastatic disease, we need to know MSI, I would argue. Some of our patients, gastric for example, we need to know PD-L1 as well. And you need to be doing these tests in almost everybody. If they're positive for any one of these things, immune therapies are now approved in this space. They have fairly profound positive effects, and we're all, of course, chasing this, so we're going to try them in almost all of our patients. I'm surprised at the number of patients I see in second opinion, still today, where this hasn't been done. So I really think the call to arms here is that all oncologists managing patients with metastatic disease should know one way or the other, MSI or not, PD-L1 or not.